Welcome to everyone who's joining us. Looks like we have mostly health professionals in the room, but some parents, caregivers, and family members. I'm thrilled to have you all here. So my name is Dr. Katie Birnie. I'm a clinical psychologist and an assistant professor at the University of Calgary. I do a lot of work in pain in children. And I'm also here today in my role as Assistant Scientific Director of Solutions for Kids in Pain, which is a national knowledge mobilization network working to improve pain for kids and their families. And just as we get started, I'm speaking to you today from Calgary, and I just wanted to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda. And the city of Calgary is also home to Métis Nation of Alberta Region 3. So just before I get to introduce our three incredible speakers, I just want to give a brief introduction to what SCIP is and what brings us here together today. So we know that Canada is a world leader in children's pain research, but often this knowledge is not being put into practice or reaching families who have the ability to use this information in their daily lives. And this is not just true in the area of pain in kids, but it's true across many areas of health research, where it takes about 17 years before research actually gets into practice. And when all of us who are here today work with youth and children, and that's an entire childhood. So really an opportunity for us to try to bridge that gap as effectively and efficiently as we can. So our vision at SCIP is healthier Canadians through better pain management, with really the solution to improve children's pain by mobilizing those evidence-based solutions through coordination and collaboration with many different partners. And our outcome is really to try to improve children's pain management in Canadian health institutions, including many of those, both those tertiary care centers, but all of those other kind of community-based centers where children are more likely actually to often be receiving some of their care closer to home. And of course, the goal is that this will lead to less suffering for children and families, less avoidance of necessary health care, better outcomes into adulthood for children, less financial burden on individual families and the health system, and that really we're showing Canada as a leader in the use of knowledge about children's pain. We are across the country. We have 4 regional hubs. I know today has a bit of an Alberta focus, so our Western Canada regional hub is in Edmonton at the Stollery Children's Hospital, and I'm here in Calgary. And SCIP takes a patients included approach where we partner with people with lived experience throughout all of our activities, throughout our staff, and also in our governance structure within our board of directors. We have many partners we do this work with, and we're co-led by Children's Healthcare Canada, so it's a real privilege to be here today. So with that, I want to introduce our first speaker, Sarah Penny. Sarah is a professional engineer, wife, and mom to 2 wonderful teenagers. Her commitment and advocacy for children with complex medical needs began in 2008 when her son, Evan, tragically suffered an unexplained brain injury and went from being a healthy, typical 4-year-old boy to a spastic quadriplegic who remains nonverbal, tube-fed, and with episodes of extreme pain. Sarah's passionate about sharing her lived experience, working with the pediatric community to address Evan's pain and to be his voice when he cannot communicate. So with that, I'll turn it over to you, Sarah, to start us off.
All right. I assume you guys can hear me okay? Yep.
Absolutely.
Perfect.
Yep.
Okay. Yeah, first of all, thanks everyone. And I really appreciate the opportunity to tell our family's story. I do find it a bit awkward talking into the abyss, so but you'll have to be patient with me. But yeah, like you mentioned, in 2008, our family changed in a way that I actually didn't even know was possible. So my husband and I were both working full time. Our son, Evan, was just about to turn 4. His sister, Julia, was just about to turn 2. And then sort of the age where you feel like you're just starting to get to sleep again. Life's getting a little bit more normal. You're kind of working through the toddler years. And then over a weekend, basically, Evan went from, like you said, like a typical little 4-year-old to spastic quadriplegic with a pretty significant brain injury. So really thrown into this world of complex medical needs. So what happened that weekend is Evan just seemed like a little bit off, like a little bit unwell. And we sort of chalked it up to, typical toddler illness. He was tired. He'd thrown up a couple of times. And then he woke up on a Sunday morning in extreme pain. So we decided to take him over to the children's hospital. And they did a series of tests, couldn't quite figure out what was going on. I think they did like a lumbar puncture looking for infection and a bunch of other things that I, of course, can't remember because it's been 13 years now. But ultimately, they did an ultrasound and they couldn't see his appendix. And so they suspected perhaps that something had, like maybe his appendix had ruptured or there was an issue there. So they recommended surgery. And so he went in for surgery, and doctor came out after and said, everything was fine. His appendix was fine. They removed it, I guess, because they were there. And um, that wasn't the issue. And then of course in the back of your head you're like, oh wow, that's great news, but like if that's not the issue, then what's been going on? And so from that surgery he never really woke up. He basically, originally they said, oh, it could be, some residual morphine, maybe he's a little bit more sensitive or reactive to the morphine. But it was pretty clear after probably a day or so that he'd suffered a brain injury. And so they carted us off to the ICU, more testing, and realized he'd suffered, as the neurologist said, an impressive amount of white matter damage, which they attributed at that time to ADEM, which is acute demyelinating encephalomyelitis. I think I got that right. And the expectation was that he would probably improve with ADEM over the year, but in that first year, we didn't see any improvement. We probably saw a little bit of regression. And so after a year, they diagnosed him with likely a underlying mitochondrial disease that is probably a genetically inherited and sort of been sitting there dormant, and something triggered him on that weekend. Maybe he had a virus or something. And so really, we kind of got thrown into this world. Like we went from a typical 4-year-old to home a month later, or I think it was like 2.5 months later, with a child requires full care and nonverbal. And in that world, I mean, I think there's mostly medical professionals here today, but there's so much subtleties in the pain and in how you read your children and how you interpret that pain, that we really took us a long time to learn and to kind of figure out how to work with the medical professionals. And the most substantial pain Evan had, and if any of you are from Calgary, you will have heard him in the children's hospital, but there was 2014, he would have like screaming episodes. It's like a chronic pain, but it was very intense, to the point that it went from a few hours a day over many months to continuous screaming. Like we couldn't go out, we couldn't have people over. Our neighbors actually called the police. So we've had the police come to our door out of concern. And ultimately we would go to the, what do you do, right? Like you're in the community, so you have your pediatrician, but with complex kids, often the pediatrician isn't really the repository of knowledge, right? It's more the parent and the family that's working with all the different clinics and such. And this all predates like the new complex care initiatives that are going on in the outpatient clinics. But really, like we held all the information. And so we're still trying to work full time, and to take time out to go see your pediatrician or to book a clinic appointment is many months down the road. And for pain, I find it's probably the same with a lot of medications, but it's an iterative process. You have to trial and error things. It takes many, many months. You'll be sort of 6 weeks down a plan and it's pretty obvious it's not working. Well, then you have to make a clinic appointment to make the other changes. And so it's just this long, kind of lonely road of trying to problem solve things on your own. And so we would go to Emerge every now and then when it got pretty bad. And honestly, no offense to the lovely medical professionals, but if I have to give Evan's like history or have a poor medical student ask me how my pregnancy went when you're trying to deal with kids with, complex needs. So the emergency room is not the right place for families like ours either. And when you're admitted, as a family, you lose so much control. Like we're used to, again, being the primary owner of the information and key decision makers in the subtleties and the nuances of like that nonverbal world that we both work. So I can't sit in the hospital all day and wait for rounds and then wait for, the pediatricians on the, on service, I guess, or, they're putting in their referrals to the specialties and that whole coordinated approach it's challenging and on an inpatient. So I think I was exceptionally reluctant to admit Evan because it became more work for me to be admitted. And so this pain really escalated and it got to a point where I had, I mean, this was a year in, I would say, of constant screaming. And I figured our interpretation was likely that it was in his bowels, and it was hard to explain that. We would do sort of few little treatments to see, like, does this enema help? Does this help? And you sort of feel these nuances that maybe it was something in his bowels. But when we have all these different disciplines, when it's really complicated, I found that all the disciplines would tend to, like, nobody knows the answer, and it is a challenge for everybody, and everyone is looking out in the best interest of Evan, but it's so hard to pinpoint the problem that disciplines tend to point the finger to the other discipline, right? Well, it's like, no, it's not, GI says, well, that can't be GI pain. You wouldn't have that kind of reaction to GI pain. Well, kids that are not typical and don't have any other way to communicate, I believe that there are pain reactions are sometimes outside of what you would expect, what a specialist would expect. And so those types of discussions were challenging because it's like, well, no, it's not GI pain. You wouldn't be in that amount of pain. And then metabolics is like, well, we think this is just the underlying progression of his genetic disorder. And so sort of like, because the solution wasn't obvious, there was a lot of dismissing of sort of trying to find a solution. It's like, it got to the point where like, this is maybe just how Evan is. But honestly, if you're in the Children's Hospital in Calgary, you could get off the elevator on the third unit 3 and you could hear him screaming 24 hours a day. It was unbearable. So through all this, and I will wrap this up quickly, but through all this, Evan suffered a pseudo obstruction of his intestine, I guess. And he was 8 centimeters dilated, which I assume everyone seemed quite panicked in the emergency room. So I assume it's quite life-threatening. But Evan was the happiest we had ever seen him. He had this bowel that was dilated to 8 centimeters. He was blissfully happy. He was giggling, he was smiling, he was laughing. So it was pretty clear to me that, okay, we've shut down his bowels and now he is the happiest he could possibly be. And so through this, of course, he was admitted, and basically at this point, it was easier to coordinate care. It was an obvious problem. Okay, well, now we can work towards a solution. But it still took, I would say, we're in for another 6 months trying to get teams to agree that the solution was appropriate, because we decided that, probably an ostomy would be his best bet. Let's just bypass the entire bowel itself. And so trying to get that coordinated care within the hospital even really took a lot of time. And in the end, we did an ostomy, which was a bit more complicated because he had a baclofen pump we had to remove and such. But so there were a lot of disciplines involved. But the ostomy was the solution, as well as we brought in more of instead of the acute pain team that they have on service, the chronic pain team got involved, and we started on actually methadone, which was the only pain med we had never ever tried, and it worked blissfully. So since that sort of year of in hospital trying to find the solution, he's been very happy and content, which none of us actually thought was possible. And so I guess, like, the moral of my story is really with these kids, like, parents provide such a critical outlook on like, or intuition into what the root cause could be and what their kids are feeling, that it's really important to not only, of course, listen to the parent, but to find ways where parents can be involved, but not in the standard hospital way where you have to be sitting at your child's bed for 12 hours a day. Parents of complex kids are trying to live sort of typical lives outside of their kids' medical needs. So they're not available to be waiting for rounds and waiting for specialties to come in. So I think really like trying to work together as a team, but maybe in a non-traditional way to look at things a little bit differently. So I guess that's my story.
Thank you so much for sharing, Sarah. And as you were speaking, so many factors were coming to my mind in terms of how we think about identifying pain, communicating pain, the overlay with potentially other things, but how that fits in terms of the key role, the critical role of parents and caregivers in picking up on some of those things and knowing those things, and how that coordination of care or that partnership in care is so challenging, and that pain is so complex and not visible in the same way sometimes, that it adds to that challenge.
Sure. And so different, right? Like if a child can't speak, like maybe their pain, I have friends who have kids with complex needs where they'll be in extreme pain and there's zero, like they don't show it at all other than elevated heart rate perhaps. But yet, or kids can be on this other extreme where maybe the pain isn't that bad, but their reactions are amplified. So like honestly, it could be anywhere in that spectrum, right? So yeah.
No, absolutely. Thank you for being here, and we're going to move to the rest of the speakers, but I hope we'll have some time for discussion at the end, because I think as we ask you to be part of this session, Sarah, like how we learn from and make changes based on experience, and partner with parents and caregivers to make those changes, that are really critically important. So thank you.
Thank you.
So I'll turn over and introduce to Kate Ross. So Kate is a certified child life specialist who's been working in the field over the past 14 years with a master's in child life and pediatric psychosocial care from McMaster University. Kate has been working with and supporting families in a variety of inpatient and outpatient settings at both the Alberta Children's Hospital and the Rotary Flames House Pediatric Hospice. Focusing on family-centered care and the family unit as a whole, Kate has been an active member of the palliative care team, supporting a variety of complex medical and psychosocial needs. Advocating for the pillars of the commitment to comfort, Kate's eager to join us today as part of this wonderful panel. So with that, I'll turn it to you, Kate.
Thank you so much, Katie, and thank you so much, Sarah. I've had the pleasure of working with Sarah and her amazing family over the number of years, and you speak so beautifully and eloquently to both the challenges and successes of your story. So thank you so much for sharing that with all of us to give that parent perspective. So I'm just going to share my screen with us now and just discuss a few of the pillars of our commitment to comfort. So just wanted to start out, for those of you that haven't had a chance to work with child life specialists, we are part of the allied healthcare team, and we work to address the psychosocial concerns that accompany healthcare experiences by promoting optimal child development and positive coping to minimize adverse and traumatic experiences. Along with parents, families, and other healthcare team members, we use play, preparation, and non-pharmacological pain management as our primary tools to facilitate and support coping, confidence, and adjustment to hospitalization. So we are lucky enough to work very closely with so many of the parents and so many of the children, both in hospital as well as ambulatory settings, in a variety of different ways, as well as hospice and end-of-life care, respite, and day-to-day visits to the hospital. So in 2014, a wonderful initiative called the Commitment to Comfort was started in our emergency department at the Alberta Children's Hospital. This rollout included physicians, registered nurses, as well as child life, and all of the emergency department teams to really try to address and support pain and pain management differently for children and families. So through that initiative, we have since been able to roll out the commitment to comfort to the entire hospital, as well as community sites to really promote and advocate for pain management and coping and the family unit as a whole. Because we know that children do not live and experience pain in isolation. And we acknowledge that caregivers have a huge influence on the socialization of a child's fear, anxiety, memory, and pain memories and behavior. We understand the vital role that parents and caregivers play for children with complex care needs and strive to work in partnership to provide optimal pain management and comfort for children and their families. So you'll see in our first pillar is the idea that we need to make a plan. So a big piece of this is conversation. So our traditional care plan, you can see here, is a small paper document that we create with the child, and it provides both opportunity for medical education as well as increased autonomy for the child and coping and discussion. We acknowledge that if we have a plan in place for painful procedures or for pain that a child's experiencing, that they can play a role, that we can play a role, that everyone can work towards helping minimize and mitigate that pain. When we're looking at children with complex care needs, we absolutely acknowledge that the parent or caregiver plays a vital role in that process. And so we create a plan with the parents and caregivers through detailed conversations. When we are working with them directly on inpatient, that may be through bedside conversations for what has worked well at home, for how their child presents pain, as well as unique or different options that we can provide for the child. An example of that might be something like a weighted blanket that makes a big difference at home. Can we have that piece with us? Can we utilize that during a painful procedure or a moment of pain for the child? We also work really closely with families from an ambulatory point of view. So this is through specialized care plans that are created typically over the phone or Zoom with a parent prior to a hospital admission or a clinic visit. And again, these are going to be unique plans that are going to identify and address the needs of each child individually. This can be anything from private rooms to dimmed lights to minimizing number of vital signs that are needed to be done on the child, to really acknowledge where the child's at, where the family's at, and how we can provide coping and advocacy for the most positive experience possible. We also want to advocate for the use of topical numbing creams for all invasive procedures. So this is anything that's going to be breaking the skin. So this is for children of all ages and all abilities. And we want to make sure that by having the topical anesthetics in place, we know that it increases IV initiation success, it diminishes vaccination or needle stick pain, and it reduces the fear of needles in both children and adults. So something like the use of numbing cream can help mitigate some of the physical pain. So then we can also be addressing the psychosocial pain and fear that may be associated with that. We also advocate for the use of comfort positions. So research has shown the impact of comfort and normalization when you can be sitting up instead of lying down and having others over top of you. So we really advocate for the opportunity for a child to sit upright for painful procedures in a comforting, secure position with their parent. This also helps promote parent or caregiver engagement and a sense of control for both the child and the parent, as well as provide soothing touch. So you can see by a few of the examples here how they often mimic the look of a hug or a snuggle from a parent, while still providing the opportunity for some distraction or some engagement with the child that is very intentional while still in a comfortable position to feel a bit of mastery or control over the situation. You'll also notice that the bottom picture here is a fabulous young lady who is in to get halo traction. And so with her weights and her wheelchair, she wasn't able to be on the lap of a parent, but you can see mom in the corner, hand over hand, so that there's still soothing touch, so that there's still comfort and support, again, just in an adapted way. The commitment to comfort really acknowledges the importance of language, and the use of positive language for children and families, and healthcare professionals and everyone involved in painful procedures or moments of pain for a family. And so when we're using this language, we want to be speaking directly to the child and the parent. We're not talking over anyone. We're not talking about people when they're sitting right there. It's really acknowledging and engaging with everyone who is present and a part of the experience. Some use of positive language would be, as opposed to saying, this will only hurt for a second, we may choose to say, I don't know what this is going to feel like, but if we use strategies like comfort position and a nice deep breath, it won't bother you as much. Or even after, with some of the reframing of the language, we're using soothing words like discomfort and uncomfortable instead of pain or painful. We also want to acknowledge that with positive language, sometimes that's just the use of one voice. So if there's a room with 2 or 3 healthcare professionals, as well as a parent, as well as the child, if the mom is singing a soothing song for the child, then the rest of the healthcare professionals might be taking a verbal step back to allow for that voice to be the one that's heard and comforting the child during that time. Research and experience has shown that children of all ages experience pain. So a part of this commitment was also acknowledging the newborns and infants and trying to adapt and identify ways to help pain management for even the youngest of those that we're working with. So options like breastfeeding or sucrose during painful procedures, avoiding bright lights or noises, clustering interventions so that we're not having a number of painful procedures over a long period of time, as well as swaddling or facilitated comfort during a comfort position with a parent or caregiver. You can see in the bottom picture that the babe needed to be lying down, but that the parent or caregiver could still be providing that soothing touch, making eye contact, singing a song, music, all of those pieces so that the child is still feeling supported and loved during the procedure. The use of distraction is really key when we're looking at acute painful procedures. And when we're talking about distraction, this is very intentional distraction utilized to keep your brain busy. So we're not tricking, we're not fooling anyone by saying, if you look over here, we're going to poke you over here. This is the use of an intentional item to engage the visual, auditory, or sensory components of a child so that their brain is busy while the procedure is going on. And while this is happening, we can also be using that comforting touch for the child. Again, this could be a great opportunity for something like a weighted blanket, or if a child's really connected with music, maybe a partnership with music therapy in hospital, or a favorite song off of a phone while the procedure is happening. Again, we can really adapt to each child, each situation, as well as the type of pain, whether it's an acute or a chronic. So one of the biggest pieces is just to acknowledge that the caregivers are the partners. We know that it's through partnership and communication with the parents and caregivers that we'll be able to provide the highest quality supports and interventions to each individual child in each individual situation. And that this is something that's committed by the full interdisciplinary team, that everyone involved wants to provide that commitment to support and lessen pain and increase pain management for all children that are coming through the hospital doors, as well as those that we're supporting at home and in community. When we're working with children with complex special care needs, we also have the additional factors that Sarah spoke so eloquently to, of the importance of observing the child's behavior. I think Sarah gave the great example of how some children may feel high levels of pain, but it's through their reactions that we're seeing it versus those that may be feeling pain very differently and very quiet about that. So it's through those observations, it's through honoring and acknowledging the parents and caregivers and their experience of those observations in how we can best support the children and families. So we want to really involve parents and caregivers as the child's advocate if the child can't be the voice for themselves. We want to engage the commitment to comfort pillars as well as family-centered care with every family we're working with. We want to monitor physiological responses and adapt as needed. So again, how is the child telling us what their pain experience is? And we want to consider the dynamic interactions between strengths and vulnerabilities with each child. How we support one is not going to be a perfect example of how we support the next. And lastly, we really want to encourage play and normalization of life and quality of life when in the hospital and when part of clinics. So doing our very best to promote overall well-being and joy alongside of pain management and supports for the families. So thank you for joining us for that section. And hopefully it has just shed a small window on some of the current tools and techniques that we're trying to use here within hospital and with the community to help support parents and families.
Thanks so much, Kate, for giving us some practical kind of application of some of the pain management strategies and what that looks like. Some discussion in the chat already, so looking forward to pulling some of that forward after our third and final speaker today too, so we can have some discussion about what this has been like and how all of these pieces fit together. So thanks so much, Kate. So our third speaker, before we open it up for some discussion, is Dr. Tammie Dewan. And Dr. Dewan is a pediatrician at Alberta Children's Hospital and a clinical assistant professor in the Department of Pediatrics at the University of Calgary. She is passionate about improving care for children with medical complexity. Dr. Dewan's research program aims to address common comorbidities and complications experienced by children with medical complexities and their families, with a focus on incorporating personalization and patient caregiver perspectives into treatment decisions. Dr. Dewan is co-leading the Calgary arm of a national study that is testing a clinical pathway for evaluation of unexplained pain and irritability in children with neurodevelopmental disabilities and medical complexity. And she also has extensive clinical experience in treating and supporting children with medical complexity who are presenting with pain. And Tammie, I'm just noticing we can see it in presenter view. So I don't know if there's a way to change that at your end, but
yeah, I think so.
Just noticing.
Did that work?
It certainly did. That's perfect.
Great.
Thanks so much. So I'll turn it to you.
Thank you so much, Katie, and thank you to my co-presenters. Those were incredibly interesting and insightful talks that you gave. So I'm going to focus on the clinical evaluation of pain in kids who have medical complexity. I prepared a few ambitious objectives, and I'll be giving mostly an overview of these, but feel free to direct me back in the discussion afterwards. So first, I'd like to describe really the prevalence of this problem in kids with medical complexity, followed by a description of why this is such a unique challenge in this population, and then to present a couple of approaches to the assessment and evaluation of pain. So my first question being, how common is pain in kids who have medical complexities? And it depends a bit what kind of pain you're talking about, and I think Kate's presentation gave such a comprehensive description of ways we can manage one type of acute pain, that being procedural pain. What I'm most interested to talk about today is actually chronic pain, which resonates quite closely with the experience of Sarah's family. And the prevalence of chronic pain in this population is just staggeringly high. So the studies that have been done have usually focused on kids with a specific diagnosis, and these numbers come from the cerebral palsy literature, in that up to 44% of kids with cerebral palsy experience pain on a weekly basis, and 28% or 1 in 4 experience pain on a daily basis. Not surprisingly, pain is one of the top concerns for these kids and their families. And the other reason why I think this pain is so important to address is because it tends to persist. Now, we don't have good prospective studies looking at the natural history of pain, but we do have cross-sectional studies. And one of those found that 60% of kids with cerebral palsy had pain, but of those kids, over 90% of them had pain for more than a year. What's maybe even more shocking is that half of those kids had no specific treatment directed towards their pain. So what's unique about pain and the assessment of pain in kids who have medical complexity? I think there's a number of different things we need to consider. One, as both of my co-presenters have described, is that these kids have a remarkable pain history. This is not their first rodeo. And some of these painful procedures and experiences and illnesses they've suffered in the past absolutely impact their future experiences of pain. Secondly, because these kids are medically complex, there's often many different reasons why they could be in pain related to medical conditions or medication side effects, technology or mobility limitations if they have that as part of their condition. So it can be very difficult to tease these things apart. Pain, of course, is a subjective experience. So clinically, we like to rely on self-report and people describing their own pain. This isn't always possible, of course, in kids who have medical complexity, as was outlined in the experience of Sarah's son. And in the situation where kids can't describe their own pain, we rely on pain behaviors. And pain behaviors are also quite complicated for a number of different reasons. One is that the behaviors can be quite child specific. And again, as Sarah described, some kids have these and actually Kate as well, some kids have these internalizing manifestations of pain. So they just become withdrawn and it's not an obvious situation. And secondly, with pain behaviors is that they're not necessarily specific to pain. So kids can be manifesting these behaviors in response to a variety of forms of distress. And finally, kids often have confounding conditions. And the example I would use here is kids that have spasticity or high muscle tone. That can certainly cause pain, but the reverse is also true. And a kid can be having pain and that's manifesting as high tone or increased spasticity. So it can be hard to know which condition to target. So what are some of the causes of pain and pain behaviors? So the first is one we're all going to be familiar with. So nociceptive pain is when you hit your finger with a hammer or twist your ankle on a run. It has a self-limited quality most times, and it also has a function in that it's trying to prevent us from further injuring ourselves or prompting us to seek medical attention. In contrast, neuropathic pain is different in that it's related to the abnormal firing of these neurons. It's abnormal pain responses. And one of the conditions that can occur in kids with medical complexity is something called visceral hyperalgesia. And I don't know Sarah's family in a clinical sense, and I don't know if this resonates with their experience, but this etiology of pain as coming from the gastrointestinal tract is definitely something that's perceived quite commonly. And visceral hyperalgesia is an abnormal sensation a sensation is experienced as painful when it should just be mildly painful or even not painful at all. And this is due to sensitization of some of these nerve fibers. Some kids are at risk of this just because they've had inflammation in the gut in the past, maybe from untreated reflux, or they've had abdominal surgeries like a G-tube insertion. And then they go on to develop these types of neuropathic pain profiles. These kids can experience things like even mild constipation or bolus feeding as being a painful experience. Another thing that's talked about quite commonly in kids who have medical complexity is this phenomenon of neuroirritability. And this is just a descriptive term. It describes a child who's becoming irritable or distressed that doesn't have an obvious physical trigger and that doesn't respond to sort of typical comfort measures that we would normally hope would be helpful. We do not know the pathophysiology of this condition, nor do we have a specific diagnostic test. So this is really a diagnosis of exclusion. And finally, I wanted to just touch on the fact that some children do have an emotional or psychological trigger or contributor to some of their pain behaviors, and this needs to be considered alongside. Sometimes we'll use terms like agitation or irritability to talk about this type of distress and these types of pain behaviors that are more related to, a situation or an emotional trigger. So what should be our approach with these kids? One of the things that I would emphasize right off the bat is the need for screening. So historically, I think the healthcare system and providers have not necessarily been attuned to the pain experience of children in general, and especially children who have complexity. So I think the onus is on us as clinicians to integrate these types of screening questions, especially given the prevalence of pain. And of course, as everyone has emphasized so far, parents and caregivers are an incredibly important source of information, and they really give you the clues to what a pain behavior looks like in their child. So assessment for pain has to be multimodal. Of course, if kids can self-report, they should be supported to do that however possible. But parent and caregiver reports of behavioral manifestations and sometimes clinician observations, including physiological measures like I think it was Sarah mentioned that with one child, sometimes just a heart rate being elevated is really the best indicator. And what's also sometimes helpful is measurement tools. And there are a few tools available, which people may or may not be aware of, that can help with this assessment of pain and also help in the reassessment of pain. So the one on the left you might know is called the FLAC, and this is a standardized measure that can be implemented by both familiar and unfamiliar caregivers. The one on the right is the pediatric pain profile. That's a bit different in that it actually first questions parents and caregivers about their child's specific pain behaviors and then uses that measurement with future pain assessments. So those can sometimes be helpful. So if we identify that pain is present, then what do we do? I like to use, well, of course, we want to identify the cause of the pain. And I like to use this analogy of this little detective, because establishing the clues and patterns are really the most helpful way to get started in evaluating the pain. And I find it particularly helpful to talk about any predictive qualities of the pain. And those can be things like time of day or potential triggers, or specific situations or circumstances or settings where the pain is more likely to occur, in addition to your typical kind of medical pain history. I would also mention at this point that it is really important to talk about the psychological and emotional contributors to pain and pain behaviors. And this is also a very important time to do that. I usually ask about things like stressful life experiences or major changes in the home, as well as screen for some psychological symptomatology, which even in a child who's nonverbal is still possible, asking about things like mood, enjoyment of typical pleasurable activities, social engagement versus withdrawal, sleep, appetite, all the usual things that you would think of when you're wondering about either a coexisting or a primary mental health diagnosis. So one of the limitations that we currently have is that there are no established guidelines to kind of help clinicians work through these really challenging clinical scenarios. And as Katie mentioned at the beginning of the talk, I'm involved in a national study that's trying to address this deficit. So this study is called the Pain and Irritability of Unknown Origin Study. We're part of the Child Bright Network, for those who are familiar with that, and funded from CIHR. And what we're trying to do with this is develop a pathway that will move kids efficiently and directly through a pathway that will establish whether they do have a specific treatable cause of pain, or whether we should be thinking about moving on to just empiric pain treatment. So I'll just share with you what it is that we're in the testing phase of right now. So this pathway moves quickly through two steps. The first step is just a comprehensive directed history and physical examination that's quite specific to the child's pain. That might result in some confirmatory or diagnostic studies, or even a working diagnosis that can then be treated. If not, then we move forward to a screening step. And the intention of the screening step is to identify these potential occult causes of pain, where there may be painful conditions that we just don't know because a child doesn't have the communication abilities to tell us exactly what's going on. And if after those two steps there's been nothing found, what we advocate for is to, and what we recommend is to move forward and start a plan for treatment, assuming that the pain could be coming from neuropathic pain or neuroirritability, neither of which has a definite diagnostic test. So that step is not part of our current study, but we are planning future studies to test the effectiveness of different treatments. I wanted to share one more quick approach, which came out in the Hospital Pediatrics Journal in August of last year. This is actually more directed towards the acute presentations of pain in kids with medical complexity. It was developed in kind of an inpatient and emergency setting. And you'll see there are some similarities and differences. So this approach also recommends moving quickly through a comprehensive medical history and physical examination. And then assuming the child is either unwell or having severe pain, they recommend 3 different steps. The first step, similar in some ways to the PIUO study, is to do some screening tests. But the intention of these screening tests is to make sure there isn't some very serious or potentially life-threatening condition that needs really emergent evaluation. This is followed by a step B, which actually works the clinician through a systems-based differential diagnosis, which is provided in this article, which I think will get put up in the chat. And then if that still does not reveal any investigations, then there's a recommendation around some further investigations to look for occult sources of pain. So I will try and share some of these resources because I think they can be really helpful. And I think to comment very quickly on some of the struggles that Sarah's family had with kind of getting a comprehensive kind of evaluation and treatment plan for pain. I think that's a very common problem. I think having a clinical pathway would empower families and frontline clinicians to really tackle this problem of pain and also feel comfortable moving into treatment even without a definitive diagnosis made. So sorry, I should have put up the resources for you. So that concludes my part of our presentation, and I'm really happy to have any questions or further discussion.
Wonderful. Thank you so much, Dr. Dewan, for that presentation. So I'd love to invite back Kate and Sarah to join us as well. And Tammie, feel free to stay with us. There you are, perfect. Don't want to lose you. Thank you for those resources being shared. Please, anyone who's here, please submit your questions. Happy to have some of that discussion. There was one question in the chat earlier. I think it was during your presentation, Kate. Just wondering if you can speak to how the adapted care plan, or if the adapted care plan includes children involved in co-developing them.
Yeah, absolutely. Thank you for that question. I'm glad to have had the opportunity to clarify. So the specialized care plans I was referring to, some of these would be specific to pre-surgical interventions. So it would actually be a phone call with a child life specialist as well as a parent directly. So one example would be we had one patient who had quite severe autism, so was not able to communicate for himself. So through conversation with his mom, was able to identify a number of different triggers that would have made his hospital experience quite challenging. And so through that conversation with the parent, we're able to identify those triggers and try to mitigate some of those. So for example, he was one that needed the low lights and low voices, as well as minimal vitals being taken, as he was quite sensory sensitive as well. So through that plan, they were able to create a plan where he would kind of come in without having to wait very long in pre-surge, and then after anesthesia would have the IV placed afterwards, so we didn't have to kind of be awake to experience that piece, as well as a lot of those pieces he could wear his own pajamas in. He didn't have to wear the hospital clothes that would irritate him, as well as some of those comfort items that he would have from home. So the child is absolutely a part of the plan, but we are just using the support of the parent to be the voice of the child, to find out all of those triggers ahead of time to make a plan that will best support everyone involved. So
wonderful.
Thank you so much for the question.
Yeah, no problem. Sarah, not to put you on the spot, but you may have questions and thoughts, after listening to some of to Kate speak and to Tammie speak as well. And no pressure to answer right away, but wanted to give you some space to kind of react to some of the other information that's been shared.
Yeah, no, it's really interesting. Actually, I had a quick follow-up for Kate. So that example where you just mentioned, like, how would a family initiate that discussion? Like, because normally, like, if you are in for pre-op, you just get a call from the scheduling nurse and such. So how does that happen for families?
Absolutely. So this can either happen.
Kate, can I add to that too? It actually, speaking to it from a parent perspective, but also someone put in the chat, a community pediatrician. So how do we initiate comfort care plans either by families themselves or by community care providers? Just because I'm imagining there's probably some related process there. So yeah, please.
Absolutely. Thank you. So for children coming in into the hospital for acute procedures or surgeries or clinic visits, this can be either put in through the physician directly to Child Life, or families can actually reach out on their own through child.life. I'll put the website, or sorry, the email address in the chat box, but they can reach out to Child Life themselves or have a physician or care provider reach out out to Child Life here at the hospital. Sadly, we don't have Child Life in the community, but again, if there are medical procedures that are happening quite often and that support may be needed in a variety of ways, then families or pediatricians can reach out again to Child Life directly to see what supports we can put in place for community settings. So it wouldn't be a person per se, but it could be the initiation of that care plan or ideas, resources, supports in a variety of ways for a variety of different needs. It's not just the acute pain. It might be fear and other pieces. I know our team works very closely with a lot of children needing to go to dental clinic. So some of those, how do we help support happy visits? How do we help support some tools and techniques, some practice and planning ahead of time with that? So I will put the email address in the website, but physicians or other care providers can absolutely reach out to Child Life as well.
Wonderful. Thanks so much, Kate. Really helpful. I'm wondering, having worked with youth with medical complexity in a variety of times in my own kind of clinical practice, and also speaking on, like on behalf of an organization like SKIP, how do we change culture around this? Because we're often trying to, in my experience, pain is often dismissed or ignored, or not asked specifically of families where children might have medical complexities, or we're asking for exceptions, which I put in quotes because I think those of us who kind of speak a similar language don't necessarily see these as exceptions, but more as how care should be happening all the time. But I've certainly been in a position where needing to advocate to other health professionals to say, can you do this? It might be different than how you would like to or how you would normally do it, but it's the right needed way to make it happen for this family. So just wondering, maybe it's a question for Tammie and Kate, and Sarah, would love your reflections as well of how do we shift kind of this this culture of not asking about pain or not navigating kind of changes to really meet and suit a child or a family's needs to manage pain in these contexts. I realize it's a large question, but would just love your thoughts from the different perspectives.
Hi, Katie. I'm happy to start from my limited kind of perspective and my role. I mean, there's just a couple of things I wanted to touch on. Nothing that's going to, change the world, but I think, certainly from a physician perspective, asking about pain is a bit of an intimidating thing to do, to be honest, sometimes, because if we find it, what are we to do about it? It puts a lot of it just gives us that pressure of not only finding a cause for pain, but being brave enough to treat the pain. And I am going to talk about it as in those terms, because I think, certainly in medicine, we're really taught in a very ideological model that we find a reason for something and then we direct a treatment towards it. And I think, as I kind of described in my talk, that's not always a reasonable goal. So I think there is a room here to empower people maybe more, and empower the right people to be comfortable to identify pain and be comfortable that they know what to do about it. And that's certainly what we're trying to do in a research capacity, and kind of our little chunk of this solution hopefully will help with some of that. But I think that's a small piece of a very big challenge.
Yeah, but fair enough that when you're asking something that you don't feel you know how to answer, that's really challenging. Sarah, I wonder if I'm just noting from another parent or caregiver as a parent. Yeah, just wondering if you wanted to kind of comment or share your experience.
So it's interesting. Like I don't think I was ever asked about Evan's like pain or comfort level in all the years when we were sort of thrown into this world. And in retrospect, I don't know if all parents are like this, but I'm a bit, I'm kind of independent, and I feel like I can deal with what's in front of us. And so you don't always speak up because pain, it sort of feels like you should tough it up a little bit. Like there's sort of this feeling that it's not really a serious problem. And so it is sort of the last thing that anyone ever asked me. I never had been questioned about his pain. And it also, like chronic pain, I don't know if it's common, but it's such a slow progression of getting worse, that you actually get to a point that you didn't even notice that you got there. Like I think Ali commented in the notes here, it's like you don't necessarily know what pain looks like as a parent and what you should be looking for. So I do think having someone straightforwardly ask me about Evan's comfort level would have been helpful. Like for us, it was pretty obvious he's in pain. He'll cry and scream and such, but yeah.
Mhm. Yeah, it's a great question. Thanks for sharing, Sarah. And just, I noticed Ali just added that comment, how when your gut says your child is in pain as a parent, but you're not sure kind of how to articulate what is the evidence for that gut feeling. How do you bring that up? How do you raise that as an issue? I don't know if anyone wants to comment on that challenge, but a really real one that I'm sure many parents with kids with medical complexity have encountered.
And Katie, if I can just add to your question, like who
Yeah,
do
please.
you bring that up to, right? Like that's the other question for parents. Like if we're, parents of complex kids, we're probably in 6 different clinics. So where do you direct that question?
Great question that you've added to that, Sarah. Really, no, I mean, really important. I think these are some of the challenges. Absolutely. I don't know, Kate or Tammie, if you want to add to that a little bit too. Again, not looking for specific answers, but opportunity to just reflect and share your thoughts.
Yeah, absolutely. I think I'm always so in awe of parents that we work with those nuances, those little cues on their child that you may not feel like you are giving an answer, but in your own experience and your own knowledge of your child, there's really so much more that you know about them than we ever can. So it is so helpful to have those conversations together, even just to say, she seems a little bit off today. We've done this, and this. We've tried this. Do you have any other suggestions? Or what have you noticed at home when you might be seeing these nuances? Because you're right, every day is different. Every expression of pain, discomfort, or even unhappiness can be different. So I think that's where I really want to bring it back to that partnership piece, to say, what does this example say to you, because I'm wondering if she's unhappy with my activity or if she might be uncomfortable while her feet is running. So really that's kind of more of the conversation, not necessarily tell me the answer right now. It's just more, how can we work through this together, because we both want more than anything to learn what's best for the child and how to support. And like Sarah said earlier, so much of it's trial and error, because it isn't one answer every time. So how do we trial and error in the most comforting way for the child as well? I think would be my observations over the years with parents, and just how incredible they are in advocating and supporting us in supporting their children.
Yeah. Can I ask you, Tammie, to a bit of a follow-up question about that? I saw in your comment that, that parent gut feeling can be, potentially an indicator as well. And I certainly know in conversations I've had, with parents of children with medical complexity over the years, that sometimes I've heard the experience of, we thought this might have been progression, or, in terms of the behavioral changes you might see in the context of pain. But then we treated pain and then those improved. And just speaking to your comment about that bravery and of what do we do to treat it, and Kate's comment of trial and error, how does that, I'm just, a difficult question, I appreciate, but when you're thinking about pain medications, and exploring kind of trial and errors around that in terms of treating pain in these kids, just wondering if you could speak to that a little bit from your perspective as a physician.
Sure. I guess just a couple things come immediately to mind. I think what Kate discussed around partnership is really important. I think one of the principles, there's a couple of principles that need to be integrated. One is you are going to need someone to quarterback this with you, with the family, with the child, and finding that person is really important. And again, I hope as time goes on, we're able to empower more people who'd be comfortable kind of taking on that type of a role. I think that's crucial. And then the idea, like with Katie, you were saying is, we need to not only assess and diagnose, but assess and reassess and ask about it and talk about it and follow it up and see what worked and see what didn't. And that's a really continuous process that I think for a lot of kids is lifelong. There are actually some reasonably good guidelines out there for how to empirically treat with medication, meaning treating it because we know it's painful, but not knowing where the pain is coming from. And there are first, second, third, fourth line medications that at least have widespread use, if not evidence. And I think, again, having the partnership with the family and the courage to start down that path is, I think, a really big part of alleviating some of this suffering that perhaps is unnecessary in some cases.
Mm-hmm. Thanks for sharing, Tammie. Sarah, maybe to follow up on Tammie's point, yes, I see, Gemma, your comment, I think it picked up on Tammie, so maybe I'll ask it of Sarah. It was this question of, if as from a physician's perspective, is it helpful or is it frustrating, to walk along the journey, with a parent when maybe you don't have kind of the answers, and you're trying to empathize and facilitate kind of this trial and error. Does that feel supportive, or does that add to frustrations, in the way Gemma put it with the system? So just wondering, Sarah, what your thoughts are to that.
Yeah, so I know Gemma out of Calgary, I believe, right? So
yeah,
Gemma has actually been instrumental in helping us navigate Evan's, I believe it was, we've had so many pain episodes, but I believe it was the big one where he was in for about a year. And for us, having a physician who can sort of walk along with us and help us navigate is very supportive. Like it's as long as they're sort of, as long as personalities align and goals align. Like not everyone's necessarily a great fit, but it can be really lonely as a parent trying to navigate all the different medical disciplines, trying to be that coordinator. And so having an advocate who is aligned with a long-term goal and help you sort of navigate that system is wonderful. It's amazing. It's empowering for sure. So I truly support it and really appreciated it.
So perhaps a good takeaway for those healthcare providers listening that maybe are feeling uncomfortable about how to manage and how to treat pain, being willing to put it out there, even if you don't have the answers, but to have that conversation and to be that ally and advocate along trying to attain that same goal is supportive in moving it forward in some way. Yeah,
for sure.
Yeah,
for sure.
Awesome. Thank you. I know we're at the end of our time. I know we started a little bit late, but there's one more question in the chat that maybe we can just use to finish us off, related to culture. So Isabel just commenting where she's run into trouble is with health professionals is where their commitment to supporting pain management or best practices is where her non-typical kid didn't react in a predictable way. And then it interrupted kind of the workflow or timing of other things that were happening in the health setting. And doing the right thing meant putting them off their perceived schedule. So how do we put the pain management of the patient in front of them as the primary priority? So maybe just a last comment from everyone on that topic, that question, and then we'll finish for today, but I'll leave it with that question. So maybe Sarah, I'll give you the last word as the parent, if you don't mind. And Kate or Tammie, do you want to just react first about, from your perspectives, how do we make sure that pain management is the primary priority, even above and beyond some of those other priorities that can come up for health professionals?
I'm happy to go first, Kate, if you like. So that's a big question, and I think a really important one, Isabel. And we had conversations about this before. I think some of the efforts that are going on now, over like with SKIP and commitment to comfort and these sorts of things, do help to elevate this issue and prioritize this issue. And I think that's going to be really instrumental. But like, I think it was you as well that talked about a culture change, and that's obviously a different type of process and can be quite a frustrating process in some cases. But again, I think the more we talk about pain, especially in kids, that don't have the ability to report and describe their pain like we like people to do, is going to help and is going to get more people on the same page that pain is the top priority and comfort is one of the top priorities we have, and we need to be acting with that in mind.
Perfect. Thanks, Tammie. Kate?
Yeah, thanks, Tammie. I totally agree. I think one of the pieces we have seen throughout our shift towards the commitment to comfort over the last number of years is the idea that if we're talking about things like pain and we're talking about how to best cope with pain, we're also finding that it is helping mitigate the time something might actually take to support, because we know what may work best, or we know through trial and error what may have been positive in the past to try first the next time. So I think through having these conversations, through making plans, through working together with staff and families, I think we're gonna find comfort faster than if we kind of just shoot at it blindly without having the conversations. So I think opportunities like this and opportunities to talk to parents directly on admission or prior to stays is so helpful. So thank you for being a part of it.
Awesome. Thanks, Kate. And then Sarah, maybe I'll give you the last word on this, or anything else you want to say to finish us out.
Yeah, no, I sort of reiterate what Tammie and Kate say. Like, it's like, I understand, like, the medical system is strained. Everyone's busy. Everything's over capacity, like in our experience here in Calgary. And, you know, sometimes the rush or that perception by some of the doctors that if they take that extra time, it's going to make things longer and put back what they had planned in their schedule. But again, it comes down a bit to that mindset change and that culture change, which will take a very long time. But, and to kind of reemphasize what Kate said, like, if we do that culture change, it could become more efficient in the long term. So there is some growing pains in really putting that emphasis on doing things a little bit differently. And for families like mine, and from Isabel had the comments there, it can be frustrating. I'm probably a little more patient than some families sometimes, whereas, like, I understand the limitations, but it's not right, but sometimes it's just the world we live in, and doing that advocacy really from the parents' perspective, I think, will be one of the initiatives to help make that change, right? So
yeah, wonderful. Thank you so much
Thank
to
you.
the three of you. I'll just put up here too, it was a thrill to be part of this through Skip, and just wanted to put up some resources. You're welcome to join in our kind of Skip community as a person or parent, family caregiver with lived experience, or as a health professional. We're also on social media and also have a newsletter. So do feel free to reach out. We're continuing to kind of work and identify this space as critically important for somewhere where we need to improve pain care for children and their families. And just a huge thanks to Sarah, to Kate, and to Tammie for joining us, and for all of you for the great discussion. Enjoy the rest of the conference.